Hello, my name is Ahmad Masri. I'm a cardiologist and cardiomyopathy specialist at Oregon Health and Science University in Portland, Oregon, United States. We're lucky to live in a time where we have multiple therapies for transthyretin cardiomyopathy. So depending where you live, you could have access up to 3 medications that are approved based on randomized clinical trials, and these are tafamidis, acoramidis, and vutrisiran, and those are indicated for transthyretin cardiomyopathy. So there are always questions of the timing of events in amyloid trials, especially transthyretin amyloidosis. There are concerns that, well, this is a chronic disease. It takes time for things to happen. So you have a lot of time to think about these patients, work them up, diagnose them, and start them on treatment. So the goal of this analysis was to challenge that concept, because what we observe in our clinical practice as well is that patients do suffer from events while they're being evaluated and worked up. And so the goal is to see what is the effect of acoramidis as compared to placebo early on in the study, and how does it continue to evolve throughout the 30 months and the open label extension period of the study. So the key findings were that acoramidis resulted in a significant reduction in events, recurrent events, so all cardiovascular hospitalizations and urgent visits, as well as in the event of mortality, cardiovascular mortality, that was being affected by acoramidis as early as first month, and ongoing, effect and diverging from placebo throughout the trial. And numerically looking at this, the cumulative event hazard ratio in favor of acoramidis was 0.51, which roughly translates to 49% relative risk reduction when it comes to acoramidis versus placebo. So that was the primary finding of this analysis. I think the significance of these findings go beyond only the treatment consideration with acoramidis. What we are trying to change as a paradigm is the fact that a transthyretin cardiomyopathy is a time-sensitive issue. And so we would really want to shrink that evaluation period from the onset of symptoms and findings of red flags, for example, to the performance of, echocardiography, MRI, bone scintigraphy, all of these imaging evaluations, biopsy, and then establishing the diagnosis, to getting patients on medications. So the shortest pathway to doing all of that, I think, will be the best pathway, and will result, as we know now from the study, in reduction in early events. If you look at ATTRibute-CM, which is this trial, 25% of the events happened early, as defined by less than 6 months of randomization. And so it is not true that it takes years for events to accrue, and it's not true that it takes years for the drug effects to be observed. It actually does happen early. There's a question of whether this is specific to acoramidis versus not. There seems to be an early hemodynamic effect of acoramidis, but that is something that needs to be actually explored and studied in other prospective trials to understand it more, since it appeared, in a post-hoc exploratory fashion in this study. Find patients early with transthyretin cardiomyopathy, and if you are suspicious of someone having that, don't follow the usual pathway of diagnosis, taking time. Just try your best to shorten that and get patients the diagnosis as soon as possible and start them on treatment. And then the second takeaway is that we do need to study the findings that acoramidis is exerting an early benefit, to understand the mechanism of that early benefit.